Rashmi, good evening. Aigan,
Hello,
hello.
hello, how are you?
All good, all good.
As
Hope you're doing well.
usual. Yeah.
Good evening,
Yeah.
Dr. Nihaal. Good
Good
evening,
evening.
Dr. Yorjin.
Hello.
Hi.
Is that Dr. Rashmi?
Yeah.
Yes, that's me.
Yeah,
Yes.
nice to see you. Nice to hear you.
Yeah. After a long
We-
time.
We are colleagues from the steering committee. Am I correct?
Yes. The
Yeah.
distance learning steering committee.
Yeah. Okay.
Yeah, it keeps me as a student forever.
Okay. So looking forward again.
Yeah.
Nihaal, thank you very much for all your efforts.
Thanks
Welcome,
again. Thanks
Dr.
for joining
Priya. Dr. Priya is a geneticist at Apollo Hospital, and she's very passionate geneticist. Welcome.
Welcome,
Thank you,
Dr. Priya.
ma'am.
Yeah.
Yeah.
And welcome, Dr.
Hi,
Rahul.
sir.
He's a neuroradiologist at Manipal Hospital.
Yeah. Hi, Rahul. So without further ado, I think we can start our session. I can see Apurva is logged in.
Yes.
So once again, good evening, everyone. Welcome to our bi-weekly sessions. The chat is open. Abhishek, just ensure the chat is open for all. Please put in your comments, suggestions, and any questions for the presenters and in general. So without further ado, we'll start off with our first case. I think we are around 9 or 10 cases today, all new cases, so no follow-ups. All right, over to you, Apurva.
So this child is a 11-year-old, 11 and a half-year-old male child, born of a third-degree consanguineous marriage, came with complaints of intellectual delay and seizures. The child started walking independently around 3 years of age. Speech was delayed. Currently, he was only able to have need-based communication, but no interactive communication with some disfluency. He was going to school in second grade, but intellectually, he was on par with only a kindergartner.
Yeah, Apurva, go ahead.
Poor writing skills, weak memory and understanding, and there were motor stereotypies like hand flapping. So this was the intellectual and global developmental delay. The seizure started from 9 years of age, recently 2 years back. They were in awake state, left focal tonic-clonic seizures, brief episodes. 6 to 7 such episodes had occurred in last 2 years, along with episodes of sudden onset dystonic posturing of left upper limb lasting for a few minutes, during which the child would not lose his consciousness. These episodes of left dystonic posturing, they occurred every day, more when he was waking up from sleep. So based on that, the child came to us with the scans which are available.
I think I have the image.
Yeah.
I mean, you can.
The examination head circumference was normal, 48.5. There was hypopigmented hair, dysmorphic faces, deep set eyes, maxillary hypoplasia, low hairline, long eyelashes, exotropia of bilateral of both the eyes, left thumbnail bed, there was smaller than the right one, and normal dermatoglyphics, but no neurocutaneous markers, and there was mild spasticity of the gastric nemes. The investigations which were available were IQ was 40.
Sorry, yeah.
Homocysteine was normal, B12 folate was normal, EEG had right-sided spike and wave discharges correlated with the left-sided seizures that he had, and ophthalmologically there was bilateral dissociated vertical deviation and dissociated horizontal deviation.
Okay. Well, I think we have a couple of scans. I don't have the scans, but I just have the film images. So this is done last year in March 2023. The T2 axials out here and the diffusion axils out here, and you can appreciate on the T2 axils there is some degree of volume loss in the supratemporal brain and also in the cerebellum. But again, there are some focal abnormalities, the likely gliotic changes in the bilateral basal ganglia. Also, you can appreciate there are some white matter, confluent white matter areas of gliosis in the subcortical deep frontoparietal white matter. You can appreciate the cortical thinning at that region, the perironic regions, the frontal regions, predominantly in the watershed areas, and also some degree in the perisylvian region. So we are seeing chronic changes, some focal abnormalities in the deep brain nuclei, particularly the basal ganglia, confluent abnormalities in the more peripheral regions of the brain. We have reduction in the white matter volume. We have expected dilatation of the lateral ventricles and overall reduction in the brain volume. On the diffusion sequences, do not appreciate any acute abnormalities in terms of signal changes. These are the flare sequence images. Again, you can appreciate what we have seen on the T2 weighted sequences. Predominant changes are chronic in nature. you have the cystic gliotic changes in the parietal basal ganglia, confluent abnormalities again in the peripheral regions of the supratentorial brain. On the SWI or the GRE sequences, I could not appreciate any areas of blooming in the abnormal areas which were demonstrated on the T2s and FLAIR sequences. Then we have, this is the SAT section. You can appreciate that there is again some degree of volume loss in the entire brain. Also, the mid-sidal sequence, you can appreciate the corpus callosum also demonstrates volume loss. On the CT scans, I think was done possibly to look for any mineralization or calcification. Based at least on these images, I'm not sure if these are punctate abnormalities out here in the basal ganglia, but nothing stands out in terms of dense calcification or hemorrhage. Whatever the findings were there on the MRI are appreciated again on the CT scan. Again, focal abnormalities in the basal ganglia and confluent abnormalities on the peripheral regions of the brain. I think the question here was clinical. I mean, the radiological question was there. Is it right you have asked for basal ganglia abnormalities, differentials? Yes. So, I mean, the differentials are widespread, but this child doesn't have the typical confluent abnormalities what we see in some of the inborn error metabolism disorders as listed out here. The only findings, if this is a genetic cause, as what it looks like on the clinical picture, I thought of possible interferonopathies such as the ADAR1 and PNPT1 mutation, which can have these basal ganglia cystic abnormalities. Called 4A12 was another genetic vascular disorder, but they are usually present with some degree of mineralization or hemorrhage. So radiologically, I can say that there are chronic ischemic changes, small vessel and in the watershed territories. But other than that, I'm not able to point out to a particular point, specific diagnosis. So with that, I'll open the case if anyone has any further suggestions or comments on the clinical and radiological picture.
If I understand the clinical situation appropriately, this sounds like more or less a static condition. And this is in keeping with the MR now. So yes, this is probably not an ongoing progressive condition or a metabolic condition. And I wonder whether it's indicated to do additional genetic or other testing. Probably not.
Yeah.
Hello.
Yeah, Dr. Reddy.
Yeah, I just want to find out, this is the case. What is the history? This is the findings.
So the child presented with intellectual delay in all the milestones and
So I looked at the hyperpigmented hair, my intellectual disability, bilateral spasticity, high homocysteine. Well, it's not very high, but it's high, and white matter changes with some atrophy. Could it be something to do with the, either folate or CBL or one of those cobalamin metabolism disorders? It's a thought. Maybe we can do a methionine to see if the methionine is low or, what is it? That would be a...
Right.
Even they get epilepsy as well. So all these things can occur. Though I must admit the homocysteine is not as high as you. I don't know what is the, is it millimoles per liter or is it milligrams per ml? I don't know what the...
it was millimoles per liter, sir.
Sure, because millimoles per liter is not very high, but milligram per dl is very high. 3.6 is very high. More than 2 is abnormal. So 15 is very high. So just check that.
Yes.
Yeah, Dr. Priya.
Hi, sir. This is Dr. Priya here. I just wanted to know, is the seizures well controlled with medications or not?
Ma'am, so the child had 6 to 7 episodes in 2 years. So it is not very drug refractory. They are controlled on 2 anti-seizure medications.
Okay. And there is no worsening of the features, nothing else that shows that, right?
It is static only. The child is slowly improving gaining newer milestones. But as Sir said, it is static encephalopathy.
So genetic causes associated with something as static as this is rare, though I do agree the first thing that kind of stands out is the hypopigmented hair and some dysmorphism, ID, and those kind of features which want you to query it. But genetic.
Yeah, Dr. Priya, sorry, go ahead.
So I feel though despite all these features kind of standing out, there you might end up not getting a good variant in this case.
Yeah, Anish, want to say something?
I come back very
Yeah.
not important.
I just wanted to ask, is there any neurovascular imaging done?
No, I just have external films
No, so no vascular.
without, yeah, and only one set of films. Yeah.
I have a question to the hair. For an Indian boy, is that still in normal limits? Would you call that is just blonde hair, or is it abnormal hypopigmented?
So it is hypopigmented because it is non-familial. So usually if it is familial, then we might not give importance to that. But since it is non-familial, then it is hypopigmented for our population.
And it has a meaning. This is pathological, is it?
In the context,
Or is it just a variant?
it could be a variant, but in the context of other settings, it is given due importance.
Thank you.
Jayant raises the question of hair microscopy, and as Dr. Udani has said, possible cobalamin pathway disorder. Yeah, so these are the two suggestions I think we have Apurva as of now. Clinically, anything else?
No, so
You were thinking?
maybe like treatment wise, only if MTHFR is there, that might change, but otherwise the child is improving.
Okay. And sending for genetics or not?
We
to be
waited so
taken?
that we know
Okay.
the like
Okay.
differentials before.
Okay. All right. Yeah, I think as Dr. Udani has mentioned, methionine levels, hair microscopy to be done, or genetics. Yeah.
No,
Dr.
I
Lokesh, you
agree
want to
with.
say? Yeah, sorry, Doctor. Yeah.
No, I agree with Dr. Eugene that it's I mean, the hair could be just a red herring in this, but in the overall scheme, I thought, and there's no developmental delay in the beginning, or was it always delayed?
It was always delayed, sir. Walking by 3 years, speech also it was
Gotcha.
delayed.
Okay. And not worsening.
No, sir, not worsening.
Okay, so I think we're leaning towards more genetic, but as Dr. Priya and Dr. Boltaz has said, we may not get a variant. So you can evaluate for methionine levels, Apurva, and hair microscopy if that is done. Main case, the question raised, we thought of it on the clinical scenario, but usually, as you can see, the outline of the vessels, they are not tortuous. The flow wise are pretty, normal. So that is ruled out.
And this is an 11-year-old child.
Yeah. That's,
This may not be relevant in an Indian context, or I'm not so sure. Could his facial features be suggestive of fetal alcohol syndrome? It's got a long philtrum, no? Thin lips.
Fetal alcohol syndrome, of course, I'm not an expert, is a spectrum. What you would expect in the classical situation is first microcephaly, some cerebellar dysplasia, and a short corpus callosum. This may not be a consistent finding, but if you think IQ of 43 is due to fetal alcohol, you would expect more clinical and imaging findings, I think.
Okay, thanks, Dr. Yuji. That's helpful.
Okay, I don't see any further comments. So, Apura, if you have a follow-up or you're working this up in terms of cobalamin pathway, homocysteines, methionine, just let us know.
Sure, sir.
Yeah, thank you.
I have just one query. Would anybody think about VC syndrome here? With the context with the cerebella is not really that involved. Hypopigmented hair can be there, but they also have immunological abnormalities. So, any history of immune dysfunctions or something like that?
Not specifically, and nothing. The child is not like well to thrive. No repeated infections were mentioned in the clinical history.
Okay.
Oh, wait. We'll move on to our next case. Yeah, Apurva.
So this child is a 2-year, 4-month-old male child presented with adenoviral infection, and following almost a month's time, the child had neuroregression, such that the child had some head titubations, shaking of head, shaking while standing, not able to walk with support, no crawling, and then the child would fall back after sitting for some time, unable to hold balance of neck while standing, and new onset squint. This time, this was the first, this episode, the head circumference was 41 centimeters, microcephaly was there, squint was present, bilateral esotropia and restriction of the bilateral lateral gaze, head tremors, tremulousness while standing, reaching for objects was there, no pass pointing or intention tremors. So predominantly axial more than appendicular involvement was there.
And we have 3 sets of scans. First scan done, is this the one with 3?
Yes, so
Sorry, 2 sets of scans. So first scan done into how many days into the illness? Or
this is after the month of adenoviral infection. In May, he had adenoviral infection, and in June, when this was persistently, that time it was done.
Okay, all right. Again, slight apologies for the image clarity, but here we have diffusion axials, T2 axials, and T2 style sequences. And on the diffusion axials, you can appreciate. I hope you can appreciate the basal ganglia abnormalities in terms of restricted diffusion, more predominantly along the anterior aspect, the caudate nuclei. But also, if you see on the second panel out here, you can appreciate the extension of involvement of the basal ganglia. Coming to the T2 axial sequences, there is some degree of volume loss, some cerebellar volume loss, some supratentorial, predominantly posterior cerebral volume loss, and cortical involvement. And again, you can appreciate the T2 hyperintensities involving the bilateral basal ganglia. And on the SAS sequences, for the age of around 2 years or so, you can appreciate that the corpus callosum is also thinned. There is again volume loss of the cerebellum, but appreciate on the SAS sequences, you can appreciate the folial spaces are widened. Supratentorial also there is cerebral atrophy. So predominant changes of basal ganglia abnormalities in terms of signal abnormalities and the supra and infratentorial volume loss on these images. Again, slightly zoomed in image of the T2 sequences. Again, same changes what we have seen. And on the contrast was done. I think there was no contrast enhancement, at least on these images. Then there was a follow-up in November 2023. This is non-contrast place sequences. You can appreciate there is cerebral volume loss, and the cerebellar cortex is also slightly hyperintense, especially the lower panel. You can see in the vermis it's slightly hyperintense, and also the basal ganglia abnormalities are still persistent, but slightly more faint in comparison to the prior study. The coronal sequence better demonstrate the more progressive cerebellar volume loss. Now you can see that the cerebellum on the coronal sequences, the bottom panel demonstrates the cerebellar atrophy. Again, the cortex is hyperintense on the T2 sequences, and that sequences again demonstrate the same changes. Because progressive volume loss in terms of the prior study, the vermis again is demonstrating volume loss, corpus callosum also is thin, and there is cerebral atrophy on top. Yeah, Pura, you want to just summarize the follow-up scans here?
Yes, so the evaluation which was available to us, lactate was 30 mg per 30, TMS urine organic acids were normal, vitamin D3 was 18, biotinidase was normal, CSF was normal, and CSF lactate levels were normal. Outside they had done NMO-MOG, which was negative. And after the clinical phenotype of a progressive cerebellar in symptoms, the whole exome sequencing was sent, and that had PMPCA gene mutation, which was spinocerebellar ataxia type 2. So the specific question that we had is that the syndrome is matching with the clinical phenotype, but that basal ganglia involvement, if it is seen in this genetic mutation.
Okay, so if you concentrate on the main finding that is cerebellum, that the mutation is known to cause cerebellar atrophy with the cerebellar cortex hyperintensity. Since this is a mitochondrial gene, this is the I think a case report published a couple of years back, you can appreciate that there is cerebellar atrophy and also deep brain nuclei changes, dorsal striatal abnormalities in terms of necrosis. So this has been described in this gene variant, and also if you see that they have mentioned that Lilac syndrome features can also be seen in PMPCA variants. This is a book chapter I think authored by Dr. Bolthauser, again causes of non-progressive congenital ataxia. PMPCA is again seen. Again, the typical findings, what we usually see is the cerebellar atrophy with cerebellar cortex hyperintensity. These are differentials for cerebellar atrophy with cortex hyperintensity. I'm not listed all of them, but these are the most common ones. And again, spinocerebellar ataxia type 2 is demonstrated in this imaging finding. So yeah, that is, I think, if the clinical matches, I think we have some literature evidence of basal ganglia abnormalities also associated with it. So yeah, we have some evidence that there is basal ganglia abnormalities associated with PMPCA, but yeah, I'll open the case if anyone has similar experience.
I have a comment. I have no personal experience, but I have a comment. Can you go one slide further, Nihaal, please?
Yep.
No, one back.
Yeah.
Yeah. The slide on the right here is from the Brain publication in 2015. I have studied this because I have a great interest in non-progressive congenital ataxia. And there were about almost 20 cases from Canada, France, and from the Lebanon. And of course, there were other publications later, but this cohort here, published in 2015, was non-progressive, no microcephaly, and as I said, static. But there were few case reports after that claiming or describing different cases with different clinic and different imaging. But I think the initial description, as we see it here, it does not conform to what you have now presented now. So I'm not absolutely sure, because the imaging is probably not absolutely identical. The course is not static, and in the initial description, you have no microcephaly. So I'm just raising a little bit of doubt whether this variant of unknown significance is really the explanation.
Got it. Thanks again.
I don't exclude it, but I'm not absolutely convinced.
This child did have microcephaly though.
Yes.
Yeah, but this is not typical for PMPCA.
Yeah.
So this is an outlier.
All right. Apurva, was the mitochondrial genome tested as Dr. Priya's? Okay, yeah, already mentioned. I would agree with Anas. Mitochondrial, yeah, that would be one of the possibilities. But PMPCA is part of the mitochondrial, but yeah, there is some variability in terms of representation, as Dr. Bolthauser has mentioned.
So we have done basic whole exome sequencing, isn't it? We have not looked at the, deep intronic regions or an exomax or something like that.
No, ma'am, this is a basic whole exome.
Basic whole exome, right? I agree with sir that it is a little bit of an outlier to what we typically see. And looking at the phenotype, of course, I have never had a case similar to it, but looking at the case and looking at the variant as such, the variant in its significance, this is having very low population. It's been reported in the population a couple of times also. So we have to be a little bit careful about the diagnosis, since we can't do any functional assays to confirm this. And keep differentials in our mind as it progresses.
Yeah, Anish?
I just had a question. Of course, if we in a similar scenario with similar imaging findings, if you exclude the microcephaly, and of course now that the exome sequencing is available, could you consider the entire thing to be a sequel of a viral infection, and with a viral cerebellitis which has progressed gradually to a cerebellar atrophy?
In terms of the imaging or
Yeah, the clinical imaging, of course, if you
Clinical.
exclude the microcephaly, which should not happen. Other than that,
Again, you want to take that up, or you want?
I still think it's no, it's probably a genetic condition and not residual change following a viral infection. But of course, I can't be absolutely sure. It's symmetrical, it's progressive. Have you thought of a prenatal viral infection or postnatal?
Postnatal, I think, is the question there.
yeah, postnatal. Similar to varicella viral cerebralitis, similar pattern.
Slightly asymmetrical, maybe, Anish?
Yeah, so just for academic sake, of course, here we have the,
All right. NCL is a question. NCL, I don't think has the basal ganglia involvement. One. PDH, they like mitochondrial possibility. Prasad, Rajesh, there are basal ganglia changes earlier. Basal ganglia and cerebellar changes. To Sayoni, to symmetrical pathway. Dr. Udani, you were saying something.
No, I just was actually, I mean, I've not seen any case like this. And I was just checking the OMIM, and it has been described that you may get a lot of clinical variability. And in fact, they've described 2 children, one in adolescence and one in age 5, who develop symptoms later in life. Because they haven't, usually these are slowly progressive, that's what they're saying. So it's a little unusual to have sudden change like in this patient. But if you look at the number of patients, there's so few. I'm sure there may be a kind of clinical variability which may not be fully elucidated at present. So I think it's probably the same case.
So what do we do next? Do we test the parents now, Apurva, or do a deep sequencing as Dr. Priya has suggested? Or
Maybe.
So doing the parents will not help in homozygous variants.
Okay.
That will never reclassify the variant. Obviously, it would have come from both of them. What would be good is mitochondrial genome. I thought that it's already done. Otherwise, we'd do either ExoMax, or we kind of pair it with the whole genome low pass, which is now available with reasonable price. So if they are affordable and things like that. But I would still want to look at the C dot variant. I want to do a look at how many cases, what is the region, what's the hotspot for this particular gene. That also would help me understand if we're lying somewhere near the hotspot.
Got it.
The protein function needs to be looked at. The C dot number for the PMPCA gene had to be looked at.
Right. Thanks, Dr. Priya. Apurva, noted.
Yeah.
All right. Next, please.
So this child is a very old follow-up. She came almost after 5 years now. She's currently 11-year-old female, born of a non-consanguineous marriage. So she first presented to us when she was 1 year, 1 month of age. That was the first episode. So this time there was a fever-triggered neuroregression, motor as well as cognitive. So before this 1 year of age, she had attained all the milestones at appropriate age. So after a febrile illness, she had partial head lag on pull to sit, poor tone on ventral suspension, weight bearing was minimal on axillary suspension, increased tone of hamstrings, gastrocnemius and pronators of upper limb, and brisk reflexes. So during this time, the child was evaluated and the scan was done, and after a period of 9 to 10 months, slowly she improved, she had recovered, she again was able to walk with support, and she was able to cruise around the furniture. And another second episode happened again. It was a fever triggered neuroregression almost 9 months later. Again, she was unable to stand and sit with support. But she was this time motor was more than cognitive. She was conscious, alert, but more hypotonic, full range of anti-gravity movements, but no weight bearing, and normal cranial nerve and normal cerebellar examination. So 2 episodes of fever triggered neuroregression, and in between there was an improvement in the symptoms. So we have 2 scans of both times.
Okay, all right. Again, this is the first scan, 2014, confirmed abnormalities on the T2 sequences, bilateral hemispheres. On the diffusion sequences, you can appreciate areas of restricted diffusion, predominantly involving the peripheral regions, but also involving the corpus callosum. So widespread confirmed abnormalities in predominantly involving the supratemporal white matter. In terms of the deep brain nuclear structures, I cannot appreciate any abnormalities other than the pulvinar thalamic nuclei. Cerebellum, at this point of time, I do not see any signal changes or volume loss, significant volume loss in the cerebellum. Yeah, so predominantly white matter abnormality, confirmed abnormality on both sides. And on the SAS sequences, again, slightly pixelated images, but you can appreciate that the corpus callosum involvement is there more posteriorly, predominantly involving the middle blade of the corpus callosum. Spectroscopy, I'm not sure of the TEs. There is slight elevation of lactate in one region and the basal ganglia, but they have not put the peaks in the white matter abnormality. So yeah, that is, and I already see the chat firing up with possibility of mitochondrial leukodystrophy as the prime suspicion over here, given that the imaging findings, as described in this excellent paper, you have confirmed white matter abnormalities, diffusion restriction predominantly in the peripheral regions of the brain, can involve the deep brain nuclear structures also, but can also be isolatedly involved in the white matter structures. Think of complex 1, 2, 3 deficiencies with these genes involved. These are the main imaging findings. Middle weight of corpus callosum is predominantly involved. If the corpus callosum is affected, you can have brainstem abnormalities, deep brain nuclear abnormalities, and also can have abnormalities in the posterior fossa associated with the confirmed white matter abnormalities. So we are thinking, at least from the first scan, as a possibility of a mitochondrial leukodystrophy as the prime consideration. This is the follow-up scan a year later. Again, you have white matter. White matter changes. The diffusion is slightly reduced. It's more now as a mixed pattern. But again, the areas of involvement are in the bilateral periventricular deep white matter. On the SAD sequences, there is some interval volume loss. The corpus callosum is thinned out, but again, you have some extension of involvement of the corpus callosum, now involving the entire corpus callosum. Again, you can appreciate that the middle aspect of the corpus callosum is more predominantly involved in comparison to the outer and the inner layers. And again, you have these cavitatory changes in the white matter. 2017, 2 years later, in terms of diffusion signals, it is almost completely normal. This absence of restricted diffusion, but you have again persistent changes of white matter abnormalities, again volume loss. I think I have only these 2 sequences for the latest scan in 2017.
So the question that we had was, this child at the first go, at 1 year, 1 month, was suspected to have a mitochondrial cytopathy, and the child was started on a mitochondrial cocktail. There was a second hit at almost 10 months later. After that, the child was continued on the mitochondrial cocktail, and up to 2017 till the last scan, the parents were using the medications. Past 5 years, they have stopped all the any other medication because the child is well thriving, going to school intellectually. There are no issues. Cognitive, motor milestones, all are almost normal. So that was one question, that what should we consider, that there has not been another episode of regression and the child has been off medication, of mitochondrial medication past 5 years.
May I ask, you don't have an actual MRI, a present one?
No, I
But
don't have.
if I'm correct, you have shown MRI with improvement, with partial reversibility.
Yeah.
And there are a few mitochondrial disorders who typically are partially or completely reversible. And one entity in quotation marks is called reversible respiratory chain deficiency. This is a mitochondrial gene, and you should look at the mitochondrial genome. So this is still a mitochondrial disorder, but of a subtype leading to reversibility. This is my suggestion.
Thanks again.
And no MLD and no vanishing and no, because you have reversibility and almost no clinical findings. So this is a great contrast to the initial onset, where you have dramatic white matter involvement.
Yes, I agree. Thanks again. All right. Let's see the chat. Sridhar mentions the mitochondrial based on diffusion. Agreed. To include mDNA analysis is one suggestion. Mitochondrial complex 1 from Anandya. HABC is slightly not. It's not a hypomyelinating disorder, so it's slightly atypical. Dr. Priya, has genetic test been done? Yes. No, sorry. Apurva, has the test been done?
So actually, this child is now 11 years, so her genetic test was done in 2013. So that
Okay.
time nothing was picked up. Repeat reanalysis was not done.
I think, Pam, here we need to get a reanalysis because I think we might hit a variant here, including the mitochondrial genome as her suggested. That would be a good way to look at it.
Okay.
So yeah, at least majority of us agree that it's a mitochondrial disorder, and as Dr. Balthauser has mentioned that they can show improvement as the slide borrowed from Dr. Wolf. You can see initially at 2 years of age, they are confirmed abnormalities, and there is almost interval improvement and almost reversibility on the follow-up scan. So mitochondrial cannot be ruled out. A low syndrome, I don't think the child has ocular abnormalities or renal abnormalities, and imaging doesn't look similar to what our low syndrome looks like. It's more of a myelination-related abnormality. Dosaine, I'm not aware of the mitochondrials which improve.
Okay, so actually, I had also seen a similar child who I think around 1 to 2 years of age had a febrile illness, had a MRI which showed a white matter like a cystic leukoencephalopathy. Then the child was lost to follow up, and recently I saw him around age 5 years of age. So the insult was like a static insult that time, like one febrile illness neuroregression. Now he's again gaining milestones. So the repeat MRI which I did, so that also showed that there is some regression of this white matter changes, and the child still continues to gain milestones. So we have sent the exam, so that is awaited.
So as Sridhar mentioned, respiratory chain deficiencies can demonstrate reversibility. Yeah. But was the child on mitococktail or not on any treatment?
No, the child was lost to follow up because it was, yeah. So so we did a lactate and all that. It was normal. So if you send the exam, it's awaited. So I will let you know. Yeah.
Just a point. I mean, the question you asked about mitochondrial cocktail, I think that's more of a placebo treatment than anything.
Okay.
Just a minor point. Lowe syndrome was mentioned. This is X-linked. I think this patient is female.
Yes, sir.
Yes. Yeah. Okay. Pura, if you get a reanalysis, just let us know.
Yes, sir.
You should be hitting a mitochondrial gene.
We are keen to get your feedback.
Yes, for at least this case and the earlier 2 cases.
Sure, sir.
Yeah. All right. From Hyderabad, we move to Bombay. Basit, if you're there.
Yes, sir.
Yeah.
Yeah. So we have this 1 year old, 1 year, 11 months old boy, first in birth order, born out of non-consanguineous marriage. Illness started 20 days back when he developed high-grade fever associated with no encephalopathy, but he was irritable during the time. And this fever was controlled by antipyretics. And next day onwards, parents noticed difficulty in walking in the form of right lower limb weakness. They say it was progressive, and there was more lethargy associated with it, and he got admitted to some hospital. And within the hospital, there was worsening in sensorium within 3 days, and he developed hyperpyrexia, the documented fever of 107 degree Fahrenheit. As such, there was no significant past medical history. He was a normal child, normal birth, normal development, aged appropriate, and no history of any contact being ill, no history of any previous vaccinations a few months ago, no history of any dog bites. And there was some history of travel to his village, not exactly sure where was it.
No,
And
he had history of polio vaccine, no?
yeah, there was history of Yes, sir. OPV 4 months before, and there was some history of travel 2 months before to his village. Not exactly sure was it. And after this encephalopathy and worsening sensorium, MRI brain as well as spine was done outside.
Okay, so we have two sets of images. I'll show the first
Yeah.
one.
This is
I have
the
only
first one.
films. On the T2 axles, you can appreciate on the top panel there is some brainstem hyperintense changes involving, the entirety of the brainstem, particularly the dorsal aspect of the brainstem. The medulla is most severely affected. Coming on top, dorsal pons is demonstrating signal changes. There's overall some degree of volume loss again, and cortical edematous changes at least in the temporal lobe on the right side. I'm not sure if there are some white matter abnormalities too in the subcortical deep white matter. We have a scan which better demonstrates the follow-up. Basal ganglia, at least on the left side, appears slightly more hyperintense than the right. So yeah, based on these images, predominantly main changes are in the posterior fossa, the brainstem involvement, some cortical edematous changes, and possible white matter abnormalities in the frontal and parietal lobes, and faintly hyperintense basal ganglia on both sides, more on the left. Diffusion sequence panel on top, you can appreciate there is a diffusion in the areas of abnormal involved in the brainstem. Coming more superiorly, I cannot appreciate any significant diffusion changes on the supratemporal brain. Yeah, on the ADC sequences, you can appreciate the reversal of the DWI changes. Faint hypointensity on the top panel over here, on the bottom panel in the top slices, possible white matter abnormality is here in the periodontic region on both sides. But on the DWI changes, maybe it's slightly hyperintense or faintly hyperintense. But the main findings again are in the brainstem. The GRE sequences did not demonstrate any areas of in the supratemporal brain, no low signal dropouts, but there are some focal punctate areas in the pons out there. These first three images demonstrate some areas of blooming. Post-contrast images are not ideal, but I cannot appreciate any meningeal enhancement or any focal abnormalities on these images. Spine, you have the T2 non-contrast SAT sequence, you have long segment myelopathy, the cord is swollen in its entirety. Contrast was done, I think, for the LS spine. There is some cord equine nerve root enhancement, especially the lower panels out here. You can appreciate the dorsal and the ventral nerve roots. Cord equine nerve roots demonstrate changes of inflammatory changes. And also the posterior paraspinal musculature demonstrates contrast uptake slightly more than what we normally see. So on the contrast, there is the cord equine nerve root enhancement, posterior paraspinal musculature demonstrates inflammatory changes, and long segment cord myelopathy. Post that,
With the hospital, only within 3 days, there was worsening in sensorium and child was intubated, started on antibiotics, antivirals. CSF was done, that showed 50 cells, but protein sugar was normal. CSF biofires, cultures, everything was negative. NMO MOG was and that was negative, and the patient was started on steroids and was IVIG. And MRI brain was repeated 3 days later.
All right, so MRI brain, 3 years later, there are progressive abnormalities, especially in the supratemporal brain, confirmed abnormalities involving the subcortical, cortical, and deep white matter structures. Also, the deep brain nuclear structures are now demonstrating more areas of involvement. The basal ganglia and thalami also demonstrate areas of restricted diffusion. Brainstem chains also have progressed, as you can see out here on the top two images. So there is overall progression, confirmed abnormalities in the white matter, subcortical, deep white matter on top. In the flare sequences, you can appreciate the findings which correspond with the diffusion sequences. Edematous changes, again, involving the cortical, subcortical regions. The deep brain nuclei are also demonstrating progression in terms of the comparison with the first scan. The brainstem also demonstrates progression. Some cerebellar focal abnormalities. On the SWS sequences or GRE sequences, you have punctate areas of blooming in the brainstem structures. Could not appreciate any blooming in the deep brain nuclei abnormalities. The T1 non-contrast sequence, you can appreciate the hemorrhagic foci in the brainstem. And on the SAT sequences, again, you can appreciate the hemorrhagic foci along the dorsal aspect of the brainstem. Post-contrast images, you can appreciate some areas of enhancement, especially in the superior aspect of the left frontal region out here. In terms of the deep brain nuclei, I cannot appreciate any enhancement over there. The brainstem demonstrates some areas of enhancement, some peripheral enhancement, some irregular enhancement there. And suboccipital region, again, there were some inflammatory changes on the left side. Spinal cord was again scanned. Again, long segment myelopathy. The swelling is reduced in comparison to the first scan, but there is again overall there's a lot of involvement of the entire spinal cord. On the axial cut sections, you can appreciate the involvement of the central areas of the spinal cord, predominantly the anterior aspects. The anterior horn cells are also involved. And on the SAG contrast sequences, there is again cord equine root enhancement. Yeah, post that.
The patient was shifted to Hinduja on transport ventilation. On reception, he had GCS of 3, brainstem reflex was absent, pupils were responsive but sluggish. And there were no spontaneous respiratory efforts. Supportive management was carried, and we repeated the CSF. NMO MOG autoimmune panel was done, that was negative, and serum biotinidase levels also done, that was negative. And then extended viral panels were sent to NIV Pune, and covering various viruses like flyviruses, Chandipora, in view of his travel history, and this latest, and also rabies PCR plus antibodies were sent, both serum as well as CSF. MRI was repeated at Hinduja.
There's another MRI. Sorry, the 3 MRIs, that's it. Sorry, I have only 2.
Yes, sir. The link I had sent.
Okay.
Contacts.
Okay, you can. Is any change in the findings? Sorry, I don't think I have that in it.
Yes, sir. There was more ascending type and more normal basal ganglia. I think this one is this. The second scan is the same. So this is the same scan.
Okay, this is okay. Okay, so this is the one that I think in the jar. Yeah, as mentioned. Yeah, more involvement. Immunocompromised, not.
No, sir.
I don't think so. Okay.
Well, we did the unfortunately we did the LS lymphocyte subset analysis, which was normal, and the immunoglobulins obviously had been given IVIG, so the IgA came a little low, but our immunologist felt it was nothing significant.
NCS, someone has pointed out. Was an NCS done? Was it? No connections, right?
Yes, sir.
Yes, it was done. It showed evidence of anterior neuronopathy versus axonopathy, more likely neuronopathy. So the anterior horn cells were involved, but that was obviously seen on the MRI as well.
Yeah. So at least imaging differentials, both the infective can present it in any form, but these are the main imaging differences I found. If you're considering infective etiologies, primary viral infections, deep brain nuclear involvement, you have certain viruses which have predominance of that involvement. Anterior horn involvement, again, enterovirus, polio, West Nile virus can have the anterior horn involvement. Encephalitis and cardiac and root enhancement or inflammation can be seen in some organisms out here. I think as Sridhar has pointed out, HLH, if that is a possibility or not to be considered. This is again a good review paper which was published last year. Patterns of involvement of the viruses, though they can present in any form, but this is just a flowchart for some selective organisms involving the selective regions of the brain. Again, predominant brainstem involvement, think of enterovirus, rabies, cardiac equine. Again, enterovirus is a common condition, virus which affects the cardiac equine nerves. I think it's a paper shared by Dr. Bolthauser to me a couple of months back, and as we have seen, based on the excitotoxicity and the inflammation, the viral and associated encephalopathy can present with various imaging and clinical phenotypes. So yeah, so this is the possibilities, and yeah, I'll open the case if anyone has any further suggestions. There's no history of dog bite, if that is one consideration for ABs. Though I think cat bite, I mean, no other organisms, animals have been bitten.
No, we basically asked about, of course, we thought of rabies as a possibility.
Yeah.
And there was contact with a dog, but apparently no apparent bite. Nobody has ever, apparently got that.
Sir, did the fever respond to immunomodulation or it persisted?
No, fever actually went to 107. And after 107, I think after that, the temperature had gone, right? Was it?
Yes, sir.
Yeah, so he had gone to hyperpyrexia in the first few days, and then sort of that looked like some sort of central process. Or maybe, I don't know exactly. It just went
but then after this IVIG and steroids, the fever responded.
Yes, sir. Fever responded after IVIG. The temperature came down.
In the
not
sense
that
it came
high.
down. But whether it was response or whether this incidental thing, God knows.
Sir, if the fever is still persisting, then I think, because we have worked up extensively and majority of infectious etiologies are ruled out, then CNS HLH or
No, it's
some
not. It's
atypical
not ruled
infections
out. It's
like
not. No, the reports are still awaited. I'll just tell you the reports in a minute. I thought maybe you can discuss if anything. Anybody else has any more ideas?
because this soft tissue infections and this muscle swelling, we have seen one case with neuromyelitis, but yeah, that was one fulminant neuromyelitis. But in our area, epidemiologically, that is more possible. I'm not sure of the epidemiology in that area. But one neuromyelitis, they have this skull-based osteomyelitis with myositis, with this diffusion restriction, corticospinal tract involvement, and all those things. And they respond to a combination of meropenem plus clindamycin.
Yeah, but
So
Sridhar, this is more of a diffuse process, no? Not, I mean, melioidosis will be more CS, corticospinal tract involvement, more focal
yes,
lesions, I think.
so
Yeah.
some cases of fulminant neuromyelitis can have these things. Other thing is this
Yeah, but
dirty
there
diffusion
was
restriction.
there
Sorry,
was
yeah.
no involvement of the muscles as far as I remember. Nothing.
Sir, what was the ferritin level?
We didn't really check,
Ferritin.
frankly, because it looked like HLH coming like this. It's a possibility, yes, but the posterior fossa was
The cerebellum is relatively spare.
yeah.
Given that the other areas are involved, that would be slightly atypical.
Okay.
Is what I thought.
The second,
And
if
the
you
way this extensive spinal cord long tract, I mean the whole long segment myelitis, that also I'm not sure is very common in HLH, is it?
you're right, yeah. It's probably more enterovirus, no? This
So
sort of.
we really thought it was a viral kind of picture. We thought it was a virus which had gone, and we did all the studies for the viruses, West Nile, rabies, enterovirus. We said AFP, but the enterovirus in the biofiles came negative, but that doesn't mean it's not there. But it's just because we had seen the thing almost few days, about 15 days later or 10 days later, or whatever.
Because sometimes enterovirus you isolate from stool or from the nasal.
Yes, exactly. So we are waiting for that, but I'll just show the other reports which came back later. Can you show?
I don't have any further
Yeah.
reports.
Yeah.
But
Okay, the reports
yeah.
I'll tell you. Okay, the reports were from NIV Pune came as Chandipura was negative, West Nile and others were negative, Japanese was negative. Rabies, serum rabies came 1 in 64, which is high compared to normally you get 0.5 is the upper limit of normal. So his is almost 120 times the level, which obviously it was not because of any vaccination which had not been given. So the CSF showed trace of antibodies, but serum was clearly abnormal. And I talked to Dr. Mani of NIMHANS and I talked to the NIV people, and they said repeat it after 7 days, which we did and did not find any change. But after taking the opinion again, they still believe that you really cannot rule out rabies at present because it might take a little longer for the serum and the CSF titers to come up. Rabies PCR and the nuchal biopsy, which we did, both came negative. And right now they're in the process of doing a whole exome sequencing for rabies in the CSF. So and that report is of course awaited. In the meantime, unfortunately, the patient passed away. Now, somebody's mentioned it could be non-specific. Well, usually it's not non-specific, but occasionally it can be cross-reaction with other viruses. We are not absolutely certain. We talked about this cross-reactivity with the virologists, and it's a very unusual situation to have cross-reactivity. But yes, enteroviruses can sometimes cross-react. You might get an abnormal serum antibodies and antibodies. So that's unfortunately we couldn't get any more samples for testing. Any comments?
Genetics and genetics.
Yeah, viral genetics are being done. Viral genetics is being done. Yes, you say serum rabies is non-specific. I mean, the point is normally people don't have rabies antibodies in the blood. unless you're a vet or something and you have low level exposure or whatever, or you have been immunized. A 2-year-old child, no reason to have those antibodies. Okay. Any more comments? Nihaal, what do you think? It's possible rabies?
The imaging, is possible. Because of the deep brain nuclear changes, and there's a case report I think published with a review of literature this year itself, which has similar imaging findings to your case. I'll try and share it on the group. It has
Yeah,
more confirmed abnormality, more. Yeah, sorry.
We have actually had a patient many years ago. It was published in Journal of Virology, which was a case who lasted for 4 years. He lived for 4 years, and rabies was positive after 4 years as well from the PCR and from the biopsy. It was really that now it was sequential imaging of that patient over time showed as if rabies was going on. It was a chronic encephalitis. Like new lesions were coming up every few months. And the only difference in the immunology was that he was given the full vaccination correctly, but they had not given the rabies specific immunoglobulin locally. So it was an interesting thing. And then after that, there are many cases which have lasted for many years. There are almost about 20 cases which have been described. So it's quite and everybody has this brainstem, dorsal brainstem.
Yeah. The only thing I have not seen hemorrhage, Dr. Dani, for rabies. I mean, though I've seen very few cases. I mean, it can be part, but yeah, only thing was.
But that could be just a necrotic.
Yeah, necrosis. Yeah.
Anyway, okay.
Unfortunate, yeah.
Thank you.
Thanks. All right, over to Bengaluru, Dr. Rashmi.
Yes, yeah. So this is a child who came to my outpatient clinic, and their main concern was that he was drooling. And he has got a left-sided ptosis, which apparently they showed me photographs. Father has mild, grandfather also has, and the ophthalmologist thought it was probably a congenital ptosis. He had mild developmental delay, like he was walking independently, slightly late he was speaking in sentences, but otherwise he was well. So in view of this, I did, there was no problems at birth and nothing like that. So we did an MRI scan, and I was expecting a normal scan, but.
Okay, there are some multifocal abnormalities, Dr. Rashmi. Chronic changes, these are likely gliotic changes in the deep white matter, predominantly the frontal parietal white matter, and also in the periventricular region, particularly the posterior periventricular region. There is a reduction in the periventricular white matter volume. Ventricles are not significantly dilated, but there is, I mean, I cannot appreciate any scalloping also, but there is definitely volume loss in the periventricular regions, more predominantly posteriorly. Posterior structures are relatively spared. Deep brain nuclear structures cannot appreciate any volume loss or signal abnormalities, no cortical malformations. The corpus callosum is thinned out. Is appreciated more posteriorly in comparison to the anterior corpus callosum. There is ptosis, as you have mentioned, but I cannot appreciate any cause for the ptosis, at least on these images. So yeah, thinking of the white matter injury or prematurity, sorry. Yeah. These are chronic ischemic changes. I mean, hypoxic ischemic changes is what I was thinking of.
Okay, the radiologist
more preterm related.
Metabolic cannot be ruled out or something, but I don't think there's anything metabolic. If you think the ischemic changes, I just stop here and follow it up.
Can I jump in?
Yes, please do.
There are so-called non-significant white matter changes seen in about 5% of volunteers and normal children, imaged for tension headache or whatever. And usually these are tiny, small, roundish, but occasionally there can be larger, as in this patient. So I would consider that this is still kind of normal in the context of so-called incident, not sure whether it's a good name, but you find it in the literature, incidental white matter changes. And of course, the differential diagnosis, which is sometimes brought in, is vasculitis or demyelinating, but this is not the context. In the overall context, this is extremely unlikely. So I think I would not call this post-hypoxic because you don't have a history of hypoxia.
No, we're thinking of small vessel ischemia. Yeah, sorry.
Could it be mild?
I would just stop and don't do any additional investigations.
Yeah.
If for psychological reasons you are obliged to do something, repeat the MR in 1 year and it will be identical.
Yeah, that's very
Is
helpful.
it a mild PVL?
Sorry,
Yeah, that's what.
mild delay. Yeah, mild delay is there.
Mild
No, no,
PVL, mild PVL,
yeah.
PVL.
Yeah. The only thing is Dr. Rashmi is not
That
there's no history, but that doesn't rule it out.
no, but that doesn't mean that
Yeah,
can happen prenatally.
Yeah,
It can happen
prenatally. Yeah.
You're
I think
thinking
Dr. Rashmi,
mainly because of the ventricle, the scarring of the ventricles. Is that what you're thinking, Dr. Nihaal? There is scarring of the ventricles, which is why you're thinking there's prematurity related brain injury happening in utero.
yeah, perinatal injury. Yeah.
That's because of because otherwise, as Dr. Eugene said, you can get small white matter changes.
Yeah, you can.
We should not overinterpret these ventricles.
Yeah. No, but there is yeah, I agree. There is some volume loss though. If you see
loss of white
posteriorly,
matter, loss of
volume.
white matter.
So serum lactate is a question. I don't think that has been evaluated.
No, I did not do any.
Yeah, I don't think it's required.
Yeah,
So
I'll probably stop here and just follow
you
it
can just
clinically, I think. Yeah.
No spasticity. Anything like that.
No spasticity, no.
Okay. Yeah, then it's good enough. I mean, you don't have to do anything.
The suspected diagnosis is likely a normal child.
Yeah.
And definitely not a metabolic, or metabolic can be ruled out.
Okay, thank you very much.
Yeah. All right. Okay.
Okay, so this is the next child. I think we had Dr. Priya also who's involved in this child. So this is a 2.5-year-old female child who presented with recurrent falls and quite imbalanced when walking. She was first born of non-consanguineous marriage and there was no NICU admission. She also has slight delay in her development. So she started walking independently late and currently she's speaking 2-word sentences. On examination, she has left-sided squint and a little bit of mild dysmorphism. She's slightly hypotonic and she had ataxia, especially when turning and all that. Otherwise, no contractures. Reflexes was just about elicited and nothing else to see. I mean, she was absolutely fine otherwise.
All right. Dr. Priya, you want to add anything or do I just go ahead?
No, the ataxia was very, very minimal. She just developed it. The developmental delays were also just slightly there. I mean, not very significant delay. I had a couple of differential diagnoses, CDG, PCH, and so on, but none of it kind of made sense. Of course, the imaging will be there, but it didn't make sense. So then we had a genetic diagnosis which didn't match also.
Yeah, ataxia had improved significantly with physiotherapy. So by the time Dr. Priya saw her, she'd had 3 months of physiotherapy.
Okay. All right. Okay, we'll go on to the images, then get back to the discussion. So axial T2 sequences over here, supratentorally, I cannot find any abnormality. The main findings are in the posterior fossa, especially in the cerebellum. You can appreciate some form of dysplasia out here in the vermis. The cerebellum is also hypoplastic. The coronal sequences again demonstrate some degree of cerebellar dysplasia. SAD sequences, again, you can appreciate there is some hypoplasia of the pons also, and there is hypoplasia of the cerebellum with dysplasia. What was the time of scan, Dr. Rashmi? 2 years?
Same, yeah, maybe 2-3 months back.
All right, okay. So in terms of any hemostatin foci for any prenatal injury, antenatal injury, I could not appreciate any hemostatin deposits in the posterior fossa. Possible tiny cysts out here in the subcortical cortical regions of the dysplastic vermis. Maybe here 1 year and 1 year, but again on the SAD sequence you can appreciate a tiny cystic foci out there. Yeah, so hypoplasia and some dysplasia is what I could appreciate. Spectroscopy, I'm not sure. Yeah, it does not demonstrate any abnormality, so I don't think it should have been done. So yeah, predominantly posterior fossa changes. I do not have a, and this is the follow-up, I think. Yeah, Dr. Rashmi, if you just want to summarize.
Dr. Nihaal, I don't ask for spectroscopy, but suddenly
Okay.
the radiologist has got very interested and he wants to do
Okay.
spectroscopy and see what is there in all
Oh,
the
okay.
children I send him.
Okay.
So they're just done as
That's
because he's very
no, I was
interested.
just wondering because there was no. Yeah, that's fine. Yeah.
So all the initial sort of basic blood tests were all normal. B12 also was normal. Vitamin D slightly low. As I said, she improved significantly with physiotherapy, and her whole exome and mitochondrial was negative. So Dr. Priya, maybe you want to add?
So there was a NUP 188 variant, which did not again match the phenotype at all. It was a variant of uncertain significance seen within population. So we were able to rule it out, even clinically, without doing parental segregation. And I was thinking still in terms of a genetic diagnosis, if you could see cerebellar dysplasias are generally more common with a Walker-Walker kind of phenotype, but the child did not have the severity of that. So again, I kept it on the backside. And CDGs and PCH were what I was thinking, and thinking of a reanalysis of the exome on that basis. I'd be happy to take any suggestions from the crowd.
Eugene, you want to take over?
Just a
Well,
question.
just
Yeah.
go on.
I want to ask. Sorry.
Dr. Rani, go on. Sorry.
Yes, please ask.
Yeah, Nihaal, do you think the clavum is a little prominent?
Not as much as what would I see for INAD, if that is a question.
No, I'm not saying. I'm not saying.
Okay.
cyanide.
Okay.
Because that usually it means that maybe there's a little bit of, atrophy, and that part is standing out.
Yeah, I mean, yeah, the brainstem is slightly reduced. I wouldn't call that as a hypertrophic level.
Okay.
In terms of descriptive, I would just call this cerebellar hypoplasia. And the diagnostic yield of this in genetic testing is disappointingly low. So we are not even sure whether this is genetic, could be also acquired, I don't know. But it does not conform to a characteristic cerebellar malformation. We can't say more. It's very, very heterogeneous group.
Agreed. So I think the genetic yield could be quite less, but we were just thinking anyways, as whole exome sequencing was done. So we will just reanalyze it and check whether all the variants and all the genes are covered.
Yeah, at least, yeah, thanks. Yeah, it is in terms of imaging, I agree with
So it may have been an antenatal insult, right? Some sort of vascular insult causing hypoplasia.
May have, if there was some hemocydin, I would have been more confident, but still possible is, I think is what Agon is implying.
Yeah. In which case, it's probably unlikely to happen again. Because that's the main question, I think. That's why I went to Dr. Priya.
I think we need to reanalyze every year, or is if
and she's also
sorry.
She's also showing improvement with therapy and
she's showing
physiotherapy.
improvement with physiotherapy, so that again goes for a static insult.
Any questions from anything we
could I have just one observation, please? The flow word of the basilar artery looks very large. Is that incidental or
artifact? I think it's a flow artifact, if I'm not mistaken. I mean,
looks larger than the ICS. Much.
I can see two. I'm not sure if this is the one and this is the artifact or. Yeah. Unfortunately, I don't think we can add anything else at this point in time.
Yeah, that's helpful. Thank you very much.
Yeah, thank you.
Thank you.
If anything comes up, we will update you, Dr. Priya and I.
Sure, thanks.
Okay.
All right.
So this one is a very interesting child. So this is a 6-year-old child who came to see me 2-3 months ago. It's a 36-week baby, and initially had mild, again, global developmental delay, and he was walking on the toes, and he had speech delay. So he was referred to a different pediatric neurologist for suspicion of autism spectrum disorder. So he was told it was not autism and advised speech and OT. But after that, his balance deteriorated. In fact, I saw the videos from the parents. He was walking very nicely before, and now he has a sort of crouch gait with a little bit of ataxia. He's not very confident in walking. He also has he had dystonic posturing at the ankles. No obvious spasticity. His reflexes were slightly brisk, and otherwise no other abnormality to be seen. He had an ophthalmic examination, and there also they said no abnormality. Fundus was normal, and no other things to be seen.
Okay. All right, Rahul, if you're there, over to you.
Yeah, good evening. On the axial T2 weighted images, we can see that there is some mild hyperintense signal involving the deep white matter with sparing of the subcortical eufibers, predominantly involving the posterior aspect, more in the parietal regions. And as we can see, there is symmetrical volume loss involving the bilateral thalami with mild T2 hyperintense signal. And also on the T1 weighted images, the thalami signal was normal. And if you see on the down panel, the coronal images, there is some mild diffuse neuroparenchymal volume loss, both the supratentorial and the infratentorial brain parenchyma. And also the dentate nucleus were mildly hyperintense. And if you see, also there is some mild hyperintense signal involving the central tegmental tracts as well. The corpus callosum morphology was normal. There was no signal changes there. And even there was no signal changes in the diffusion and the SWA images as well. MRS was performed. MRS, the NAA choline creat peaks were normal. There was no lactate peak. So considering the symmetrical pattern of involvement, we were thinking of genetic etiologies. And considering the symmetrically small thalami with hyperintense signal and the volume loss, we were thinking NCL as our primary differential diagnosis. And also other differential of Krabbe can be considered because of the hyperintense and small thalami. But the genetics turned out to be negative, so we wanted to know if any other differentials you can consider.
The genetics was done at Centogene Labs, which was negative, and they came up with some variants. I think 3 were retinitis pigmentosa, which the ophthalmologist told me that is probably not relevant, but she'll have another look at the periphery of the retina. The first one, Adam Oliver's, it's a skin condition, I think. So it really doesn't fit in with the phenotype. So I'm a
And the
little
labs are all
yeah,
good.
labs B12 is slightly low. I mean, I don't think it's significant, but I've started on B12, thymine, and biotin. Parents say thymine and biotin has improved him. I'm not so sure. CPK is slightly high. Otherwise, other tests were all normal. So.
All right. And as Rahul has pointed out, imaging differentials, what we think of when we see the thalamic changes, particularly in the context of neuroparenchymal volume loss, think of these possibilities, think of lysosomal disorders. And if you see the index case and in this case out here, it has pretty similar findings. So I thought NCL was the prime possibility for this case. But yeah, we'll be open for any other comment consideration. The only thing is B12 can cause cerebral atrophy, Dr. Rashmi, but as you say, it's not very significantly reduced. But they usually do not cause these deep brain mutations. Yeah.
I may have missed it. Any ocular motor problems? And what about the ophthalmological examination in terms of fundus? Any changes?
Fundus was normal. Ophthalmological examination fundus was normal. She wanted to look at the periphery of the retina again, which she says she will do. And there was no ocular motor problems or anything like that.
And no seizures?
No seizures.
Thank you.
I had a question, Nihaal.
Yes.
Cerebellar atrophy, I mean, there is some mild sulcal prominence laterally, but I mean, usually in NCL, you get that pretty early?
I don't think in all the variants, Rani. Some of them present with more cerebellar involvement. But if you see the coronal sequences out here, I mean, it is pretty diffuse at least.
Yeah.
What lower down, I
No,
think
but
it's
it's
maybe not
like
that much.
it's similar. It's similar to the brain. It's cerebral
Yeah,
and cerebral.
yeah,
There's no difference as such. Yeah,
yeah. But some variants, I think, can be known to have.
yeah, that's possible. Yeah, so many of that. And no seizures, right? No
No
seizures.
seizures at all. Yeah, that's what 6-year-old and no seizures. So that's why.
NCL is a little odd.
Mm, and
It's
this-
odd, but it's perhaps the best option at this time. It's a
Hmm.
good option in terms of imaging.
What is the best option?
NCL.
NCL. So I'll have to do some enzyme assays then.
You can, yeah, you can do that, but you can also do a skin biopsy for electron microscopy.
Okay. And speak to the parents.
Because
for-
I think the enzyme analysis only identifies type 1 and I mean the NCL, CLN1 and 2, if I remember.
But this
They
is
may
not type
don't have
1.
No, that's what I'm saying. It's not type 1. The other enzymes are, I mean, you know, you don't get anything positive in that. Other NCLs.
Dr. Udani, sir, where do they do the skin biopsy for analysis? Where should I send it?
What's for
The
EM?
which lab does it well?
And NIMANS does it.
Oh, NIMANS does it for NCL specifically, if you ask?
Well, basically, they're looking for inclusions.
Okay.
Skin biopsy.
But it's can I jump in? At least in my area, I would not know a neuropathologist who has any experience today because everything is going via genetics. And people who have really experience in electron microscopy of inclusions, this is a vanishing species of neuropathologists.
You're absolutely right. You're absolutely right. Yeah. In fact, in NIMANS, before this genetics came along, that's one of the ways we used to diagnose HCL. And
I agree. Yeah.
we used to send it to NIMANS regularly because they had a lot of experience in EM. But you know, I don't know, the same people are still there or they've changed. I have no idea.
I'll check
I
with
think
them.
Dr. Gayatri was there, but I think now she's probably retired.
Dr.
Yeah,
Priya,
Dr.
do you
Priya?
have anything to add?
Yeah, she's here.
Yeah, I do know that in NIMHANS they're doing NCL because I had a couple of patients who did this skin biopsy of NCL from there, and both of them turned out to be negative, but still they had done the testing. We couldn't get to a genetic diagnosis. And secondly, NCL is very notorious for exonic deletions, NCL type 1, 2, 3, all three. So I feel here we need to do either some kind of an exon array, or we will be probably able to do even a genome or an extended exome to see if we can get to a diagnosis, because this looks genetic. There is possibility of finding. It's just that the variant is probably hiding somewhere. We're not able to spot it.
Dr. Priya, Rahul has a question. Can exome be negative and skin biopsy be positive?
Yes, sir. So exome, yeah, exome is very limited study. Exonic deletions less than 2 exons never picked in whole exome. Also, regions with promoter mutations are never picked, or those within the deep intronic regions are never picked. The test of choice would be whole genome, with slowly coming in. Right now, in our country, I think it's very expensive. They're doing on research basis many places, but not everywhere else. But exome is a very limited study, especially with NCLs where exonic deletions are common.
Thank you. So, Dr. Rashmi, we're agreeing with NCL and as suggestion.
So NCL as suggestion on MRI. There is no other reason for this, right? The MRI.
There is always another reason. Always, at least 2 or 1.5.
We could also do an ERG, electroretinogram, which might help.
Okay, I'll do that. I'll ask I will get that done.
All right.
Okay.
Thanks all. Thanks to Rashmi.
Yeah.
Thank you.
Thanks for that. Yeah, thank you very much.
Go to Jonas.
Yes, sir. So this is about a 4.5-year-old girl present with history of fever, loose stools since 2 days. On day 2 of fever, she had 2 episodes of seizures, one in the morning generalized tonic-clonic 30 minutes, and second at the referral center. She had hypotension, which improved with fluid resuscitation, and she was referred here. At examination, it was eye-opening to deep pain this morning. Withdrawal response to painful stimuli. She had vertical disconjugate gaze. Horizontal dorsal eye was present. Pupils were normal size, reacting to light. Very spastic. Upper limb, lower limb more than upper limb more than lower limb. DTRs were exaggerated with increased area of excitability. Extensor response bilaterally. They had come with an MRI. So this MRI was done, I think, within 8 hours of the seizures.
Just for the radiologist, Anas, what is on the video?
Just the vertical. So one right eye is down and the left eye is the horizontal level. So signifying some brainstem.
Okay, all right. Okay, we have two scans. One external scan done on 24th of July. On top is the flared axial sequences. Then you can appreciate there is the involvement of the cerebellum, bilateral hemispheres, the brainstem is involved. You have white matter involvement and also thalamic involvement on both sides. Better appreciate on the T2-weighted sequences. Again, posterior fossa abnormalities in terms of cerebellar involvement, brainstem involvement, periventricular deep white matter involvement, thalamic involvement on both sides. Some degree of volume loss, but not very significant in the supratemporal brain. Post-contrast sequences, at least on these, I'm unable to appreciate any significant enhancement. This is the most recent scan done, I think, 5 days later. You have these punctate partially confluent abnormalities in terms of residual diffusion involving the bilateral cerebral white matter structures, periventricular deep white matter structures, also extending up to some areas of particle white matter. Posterior fossa has again brainstem involvement, cerebellar involvement. Because the confluent abnormalities can be seen on the T2-weighted sequences. Only thing was the thalamic abnormalities, which was seen in the previous scan, is not seen at this point of time. Sorry, yeah, go ahead.
Yes, sir. So, in the next slide we have, I think, investigations as well. If we can share that.
Yeah, I will. So on the SWS sequences, again, punctate areas of blooming, white matter in the periventricular white matter in the right thalamus out there, brainstem and the cerebellum. And this is the investigations. Yeah.
So the child came to us overnight.
Is there any cavitation? White matter cavitation is there?
There is necrosis. I mean, I cannot. I mean, not able to appreciate the walls of a cavity, but there are some. I would say necrosis, I guess.
No, I'm saying in the sense there was some cavitating kind of white matter changes. That's what I mean. Anyway, okay.
Okay, Anas.
Yeah. So the child presented to us at overnight with the MRI. Based on the clinical radiological pattern, we were thinking lines of acute necrotic encephalitis of childhood, but of course there's no obvious necrosis. We're thinking because it's a hyperacute scan, inflammatory markers were high but not very high. PCD25, no thrombocytopenia. CRP was 9, renal function was normal. A very minimal transaminitis. Cognition profile was normal. Troponin were normal. Pro-BNP is mildly elevated. So we had done as part of radiological workup because we're seeing a lots of influenza cases with gastroenteritis and minor cough cold. We had an influenza panel, which turned out to be influenza A positive. So the initial debate was, so based on the scan, how aggressive do we treat? Because her, ANESS score was high because they had brainstem involvement, shock, and age more than 2 years. But IL-6 could not be done because the lab that day had some issues. But these were the so we went based on the extensive involvement, and maybe probably we are early in the phase. We thought we would go ahead with Plex, and the child received 4 cycles of Plex, and the image done is after the cycles of Plex. Okay. So we were not sure how much we were able to change the course in terms of neuroimaging, but the child did not require any mechanical ventilation or further inotropic support. So the main two queries were the initial scan, so nowadays we're seeing more and more hyperacute MRIs. Even in the peripheral centers, they're able to get MRI done. So would it be like, so the first debate was the ICU team, is it really any NEC or not? And how aggressive do we go with when, because the severity scoring is not taking account into the necrosis, the hemorrhagic pattern, all this they're not considering. And cytokine levels, do we target those peripheral cytokines? That was the two questions we had.
Yeah, so based on the imaging, just to summarize what you have mentioned, Anas, once the initial scan was done, you put the patient on Plex, and at least the thalamic changes on the initial scan has reduced. As you can see, it's almost completely resolved, other than this punctate foci out there. I think next question is this attributed only to influenza or is it an ANEC? Is that the question?
Yes, sir. Because so we had a debate with the ICU team as well. So with this context, how aggressive do we go, and do we wait, or do we get ahead of the disease or we wait? Because especially for Plex, because Plex removes peripheral cytokines, but if the peripheral markers are not very high, what are we chasing? That was another debate we had. So do we go with the clinico-radiological pattern or?
Okay. Yeah, I'll open the
Yeah.
case.
Yeah, child received tocilizumab as well at the night, but then next day we thought we'll go with Plex as well based on the such severe brainstem involvement.
What is the liver function test?
Bilirubin was normal. Transaminitis was there. SGOT and SGPT. SGPT
So
45.
very minimal.
SGOT 90. Yeah, very minimal.
Right?
Yes.
Because there seems to be a disconnect between the brainstem involvement, the shock, and the liver function abdominitis or mild. The thalamic abdominitis did not show any evidence of any hemorrhage. Yeah, so there seems to be a disconnect between the radiology and the clinical.
And the thalamic changes have improved, Kodani, in 5 days.
Yeah, which is very unusual.
Yeah.
Because with these changes, it's becoming more. Because so how do we anticipate? Do we go ahead of the disease or do we wait, or what should be our target here? Especially if the cytokine storm is very high, it's very clear, but there's a disconnect, like you said. Do we go
so
ahead?
do we give Plex or not is the question.
Yeah. But we don't know the child improved despite of it, or just because child receives steroids as well, steroids, tocilizumab.
Have you done IL-6 levels?
No.
IL-6 at onset could not be done. That day lab broke down. But sometimes we are seeing this thing as well. IL-6 is not very high sometimes. So. Because we're seeing a recent surge of, because of the viral season, I think more and more and coming very early, day 1, day 2, with brainstem changes, and sometimes very dissociated MRI and clinical findings sometimes, or dissociated MRI and cytokine levels.
Sridhar asked for CSF infection. I think influenza was not.
Influenza from the throat, sir.
Okay, sorry. But CSF wasn't done. Or was it done?
Yeah, CSF wasn't done.
The Plex doesn't remove the very small immunogenic things, right? That's my understanding. It removes only the bigger ones, depending on what filter you use and all that. So.
But are there any other differentials other than NEC for the first radiology? For the first
it'll be viral. I would say viral related changes.
When you see these punctate kind of lesions, is it suggestive of a viremia? I mean, or sometimes in bacteremia also you can get these small lesions everywhere. You know,
Yes, 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 Dr. Dani.
our radiologist always talks about that as a, and if you look at the junction of the cortex and subcortical regions, you get the small little areas, very vascular kind of thing. Yeah. How is the child? Is he better?
Yes, much better. We have sent them home actually. But child still requires, I mean, the eye opening is improved. The disconjugate gaze is improved, but still on NGA tube feeding and lots of spasticity. This motor response is slightly better, but they wanted to continue further care at the referral center. So child has been discharged, but not to home.
Question of EEG.
He just had diffuse cerebral dysfunction, delta wave with normal amplitude, no electrographical seizures.
Yeah, diffuse slowing, no AD. Okay. What is the current treatment followed by the IC team, or
So we went
stopped
ahead
Plex?
with So child received immunomodulation in the form of steroids and tocilizumab, and then Plex 4 cycles with it. And after the imaging, we thought there's quite satisfactory. At least the thalami changes had improved. So and the child did not require further ventilation and inotropic support. So we were happy with the improvement, and we continued with that and some supplements.
Yeah, CSF is going to target cytokine levels, not in CSF infection. Okay. I think
Another query I had was like how helpful would cytokine level from the CSF would be, because would it help in, because at least as a biomarker it would help.
See, last time I tried to do cytokine from the CSF, I was not able to do it. I could only do blood. And what I found was just exactly what Dr. Sridhar has said. It is not directly proportional to the child's clinical symptomatology, but at least when you give drugs like tocilizumab and all that, then it's useful to tell parents that it was there high, and one child did come down, an ANIC child where we gave tocilizumab, the IL-6 did come down afterwards. So it's easier to say that. I'm not sure there's direct correlation or anything like that.
Don't think that the labs which do these levels now, they are not standardized as of yet in India. So you will get some different results in different labs.
Actually, it's being done in Tata Cancer Hospital, Tata Cancer in Navi Mumbai, where you can get the entire panel of CSF interleukins, right? I think they do some, everything, the tumor necrosis factor, IL-6, IL-8, IL-10, etc. So the only problem is transport from out of Bombay. So I don't know, you have to talk, if I can, in the group, I'll put the name of the person who does it, the phone number, and you can talk to him and see if you want to send it, because it's really very useful. We use it, I've been using it for fires, so, and it sort of helps us to decide whether to give tocilizumab or not to give tocilizumab, etc. And the answer comes in a day or so. So it's really something worth it. It's very well standardized.
We'll look into it. Thank you.
All right. So we'll move on to our next case. Then, Anas, thanks for the case. And so last case, Dr. Saini, over to you.
Yes, so this is a 10 years old boy who actually is symptomatic since last 4 months with a persistent high-grade fever of 103, 104. And then he also started 1 month later having headache, and now also has vomiting since last 2 months. So his mother had a history of pulmonary coughs 4 years back. She took treatment. Otherwise, the child was a well-thriving child. So the child was actually admitted outside another hospital for quite a while, like 2 weeks, where she was diagnosed as a CNS tuberculosis and was empirically started on ATT with steroids since end of June. So that papers mentioned that he had meningeal signs, but however, when he presented to us, the current symptoms are only being persistent high-grade fever, although headache and vomiting has settled down. So there are 2 sets of MRI, one at the end of June and one 1 month later.
And this is how many days into the illness?
So it is like in the end of June. So it is like 26 June.
20,
So it's
okay.
20 June. Yeah, it is like 1
20
week
days.
maybe.
Okay.
Yeah,
1 month.
like,
All right.
yeah.
Got it. Okay. So we have the T2 axials and the non-contrast T1 flare axials. As you can appreciate, the predominant abnormality is in the left frontal region, perisylvian region out there, with significant edema. There is the volume loss in the supratemporal brain, more in cerebral hemispheres than the cerebellar hemispheres. On the T1 weighted non-contrast flare sequences, you can appreciate the circle has this cortex and circle has T1 hyperintensity is possibly suggestive of some hemorrhagic foci out there. On the SWI sequences, you can appreciate areas of blooming in the left subcortical cortical region, frontal cortical region. And on post-contrast, there is some left meningeal enhancement out there. There is some pachymeningeal also enhancement, but predominantly left meningeal enhancement and cerebritis kind of features on the post-contrast sequences on the first scan. Following that, I think this was the follow-up.
Yeah, so so the CSF study we repeated. So there was a lymphocytic pleocytosis around 150 cells, and more than 80% was lymphocytes. The sugar was 49, protein was rest 188. The CSF CBNAT was negative. The chest X-ray did not show anything. Zero was negative. One HSB PCR was done, which was also negative. And in view of the imaging findings, like a focal hemorrhagic, maybe encephalitis, cerebritis, we had kept. So the serum fungal was also done, so it was negative. So now the child does not, on examination when presented to us, he did not have any meningeal signs outside, although the outside papers documented that he had. Now the only thing what he is having is a persistent high-grade fever.
Okay. And then there's a follow-up scan. Sorry.
Yeah. Just
follow-up scan. How many days pass?
Yeah, 1 month later.
Okay.
Like that. This is the time when he is with us, just with us. Yeah.
Okay. All right. Yeah. Follow-up scan again. You have these left frontal abnormalities. The edema is slightly increased, going down more inferiorly into the temporal lobes. Again, you have this hemorrhagic foci in the left frontal region on the T1 weighted non-contrast sequences. Diffusion, I cannot appreciate any restricted diffusion. ADC demonstrates facilitated diffusion out there. There is volume loss, which was also seen in the prior scan. On the SWI sequences, we have again areas of blooming. Post-contrast, here you can appreciate the contrast enhancement better. There is again dural enhancement, leptomeningeal enhancement out there in the left frontal perisylvian region. Basal systems appear to be clear. I cannot appreciate any other areas of enhancement. No focal lesions per se, but yeah, predominant abnormality in the left frontal perisylvian region. But I think the question here, Raktani is asking is
infective versus, yeah.
Infective versus para-immune, para-infectious is,
Yeah.
or just infection?
Yeah, infections. Well, primarily I had thought mainly of infections.
Okay. All right. Infected demyelination, hemorrhagic variant, Western syndrome. Sridhar has mentioned there's a possibility. Rapudani says possibility. Would you completely rule out fungal infection, Dr. Sayani, based on the labs, or?
Yeah, because the SWA saw a lot of hemorrhages, that's why.
And the CBNAS negative being just X-ray negative being, do we rule out?
Yeah, no. CBNAT is only positive in 30 to 50% of the
Okay.
cases, so we cannot rule out typically. But he should have responded by now of 1 month of ATT.
Okay. Tamim says I have a case of T meningitis with hemorrhage. Okay. But I think going by the common variants, I think if you think of infection, fungal would be the first with the hemorrhagic changes. TB, as you mentioned, can be possible. Biopsy is a question. I think that is the next step.
Yeah.
Is that right? Yeah. ADA
Yeah.
levels. Raji asked for that.
So ADA is not that specific. So
Okay.
so like tumefactive demyelination is a strong possibility in this context. Nihaal.
Only thing is I've not seen meningeal enhancement for tumefactive demyelination.
Yeah.
That was the only thing.
There were like around 150
the Western
to
House
200.
syndrome, which I think they mentioned, acute hemorrhagic leukoencephalitis, that would be possible, but only thing was meningeal enhancement was slightly difficult. CSF galactoman was done.
Yeah,
it was negative.
it was 1.6, 1.7. Although we have started on thinking maybe could a fungal aspergillus and all. So we have given the treatment like almost 5-6 days, but he has not responded to that. Now what he is having only a persistent high-grade fever.
Not, I mean, I was just thinking remote possibility of spectroscopy wasn't done. That's just to rule that out.
No, it was not done. We can ask for it.
I mean, if you're going with a biopsy, then I would.
Yeah, we have planned for a biopsy.
I think it's biopsy should be best idea.
Yes, sir. So do you feel it's a tumefactive demyelination, sir? Like the
question is, it's possible, yes, but hemorrhage has been described. It's not usual. This has been described, but this meningeal enhancement, I agree with him. It's a lot.
This is a pachymeningeal and like more common was cerebrite.
Bone marrow not done, Dr. Simon. I was just thinking remote possibility of.
The blood picture didn't. Yeah, it's not done. It's not done. Actually, the child is otherwise well.
Yeah, subacute beat can enhance, but this is the second scan is the 1 month. I think 1.5 month or 1 month into
1
the
month,
illness.
1 month.
1 month into the illness. So
the
enhancement has actually progressed. If you,
and I think the treatment has also a little progressed.
Yeah.
Hi, this is Dr. Shah. Hello.
Yeah, Dr. Shah, please go ahead.
Yeah, hi. Yeah, so I agree with Dr. Udani that I think biopsy is probably the way to go. Looks less likely to be tumefactive demyelination based on the meningeal enhancement, the pattern of enhancement, and there's no obvious tumefactive, like, normally
lesion.
What MS looks like. It's not like that. I don't think this is tumefactive demyelination. Couple of things is suggestions is a perfusion scan to see what the perfusion looks like in that hemisphere, especially that lobe, and to see, because again, less likely to be CNS vasculitis, but that meningeal enhancement. So whenever you do the biopsy, please make sure that you get the overlying leptomeninges also in that area, and do some vascular, blood vessel imaging on the biopsy, just to make sure there is no inflammation, perivascular and intra, within the vessel wall itself, if you have lymphocytic infiltration, because your management will change based on that. Have you treated her with this? Have you treated this child with anything so far? Sorry, I missed part of it.
Yeah, so initially outside from received anti-tubercular therapy, we have started on antifungals, like maybe a fungal voriconazole we have started, but to that he has not responded. Almost now 5-6 days of therapy. So he's still having this persistent fever.
Right. Yeah, I mean, sure, infectious, some rare etiology is still there, but immune-mediated process is also top of the list with an infectious process. So question is, after you've done covered with most of the treatable infectious etiologies, would you consider steroids?
Yeah, so probably maybe after biopsy.
Sure, okay. That makes sense.
Yeah. Okay.
Okay.
Thank you.
Yeah.
So
Thank you.
like fungal, if you are thinking of like which one, aspergillus, any specific you can point to? No, right?
Mostly, yeah, Aspergillus candida usually an unknown to have the meningitis type pattern, but I'm not very sure of the specificity.
Okay.
Does it make a difference? Sorry, once you get the
No,
biopsy, will
the
they cover?
choice of no, the choice of
The choice of
antifungal.
antifungal. Okay.
Yeah.
All right. Okay, do let us know if you have once you get the biopsy results.
Yeah, sure.
Anish, yeah.
Yeah. Just one suggestion. I've seen only one case, so I don't have much experience. This kind of an appearance. Would you entertain the possibility of an amoebic meningoencephalitis? Or
Clinically, there is only fever. Yeah, it looks like some chronic indolent infection, but very hard to say which one is it.
Yeah, so on the CSF, was anything specifically checked for? No, not really. Under the
No, we
microscope.
didn't.
No.
Yeah, we didn't check for. Yeah.
Never really seen
Anybody?
a case, but would that survive for a month?
Yeah.
Yes, sir, that is atypical. I think
So the
you
child
can
is symptomatic for 4 months.
4 months. Yeah, okay. So,
Yeah.
4 months, my God.
Is leukemia a possibility? I was just thinking, given the announcement and the hemorrhage, but yeah, more likely infective, I guess, or immune mediated than.
Yeah.
Herpes was ruled out. I mean, it's not the age anyway.
Yeah,
The chronic
HSV
granulomatous. Yeah, sorry.
HSV PCR was done. It was negative. Yes.
I think there's a variant of herpes, the chronic granulomatous herpetic lesions. I'm not sure. Yeah. Okay, I think we're all pointing out towards the biopsy and. Okay.
Okay. Thank you.
Okay. Thanks for signing.
Thank you.
And that's our last session. Thank you once again, everyone, for sending in your cases and for your active participation. We'll see you again on the 16th of August. Please send in your cases by the 14th. You can email me or the link is sent on the WhatsApp group. Till next time, see you. Take care.
Thank you very much, Dr. Nihaal, and thanks everyone for your suggestions. Bye-bye.
Bye-bye, Eugene.
Bye-bye.
See you.